High quality.
Compassionate.
Family-centered.
These are three components of pediatric healthcare. Now imagine you have a loved one who's a child and is suffering from several chronic health issues. This child may not be receiving the best care at the best time. This may be your son, your daughter, your nephew, your niece, or maybe even just a close family friend. What would you do if the local pediatric hospital could not provide that care?
The Greater Los Angeles Valley Children's Center, or GLAFC, as we'll refer to throughout our presentation, is currently facing several challenges that questions their ability to provide high quality, compassionate, and family-centered care to the Riverside community. This includes a declining operating margin of $6 million, high overall cost, and uncertainty faced with Medicaid expansion. We are proposing the Caring for Riverside initiative, a strategy that relies on improving physician relationships and a value-based care model. This initiative will be financed through the Proposition 3 grant, which is a grant that allocates up to $98 million for children's hospitals within the state of California. By implementing the Caring for Riverside initiative, we will expect to see an estimated cost savings of $1.9 million, as well as an expanded primary care network for GLAFC and increased access to high quality and coordinated care.
The Caring for Riverside initiative will enhance GLAFC's mission to relentlessly provide individualized and compassionate care to every child, and it will amplify the vision to create optimal health for every child within the community.
Now, who is the Greater Los Angeles Valley Children's Center community look like? Of the people there, 28% are under the age of 18, 42% Hispanic, 45% white, and the rest are comprised of blacks, Asians, Native Americans, and multiracials. Now, with Medicaid expansion, we expect over 15,000 new Medicaid enrollees who are children. Now, we want to focus on three chronic health issues: asthma, diabetes, and ADHD. With asthma, there are over 365,000 children with this illness. Diabetes, over 1,600, and ADHD, over 28,000.
So how can GLAFC address the diverse makeup of the community, these population health issues that Isaac just talked about, and then as well as Medicaid expansion on top of the current issues of high supply and workforce expenses, higher than average ED volumes, and finally low ambulatory volumes? Through our Caring for Riverside initiative, it's comprised of two key strategies. The first is a cost reduction strategy aimed at addressing the high supply and high workforce expense. Secondly, through the value-based care partnership, we recommend that GLAFC partner with a key physician group in the Riverside area to address the high ED volumes and low ambulatory volumes and increase coordination of care. So currently, GLAFC does not have any of these cost reduction strategies in place, including a no care coordination model, and they are not prepared for the evolving healthcare market. With our Caring for Riverside initiative, we are expecting to see an increase from a weak state of performance in these areas to those of a strong one by fiscal year 2016.
Now, in order for GLAFC to move from an area of weak financial performance to that of a strong financial performance, we suggest testing value-based care models by partnering with physician groups. Now, before we really get into the details of this value-based care model, we want to go over the three other options GLAFC has. Now, the first one is the merger and acquisition. Although this could increase GLAFC's market share within Riverside and beyond, they may lose the ability to remain neutral within Riverside County. This means they may lose partnerships with pediatric providers and also adult hospitals who also provide pediatric services. They may also lose the ability to remain autonomous and be the decision makers for the patient population of Riverside. The second one is the specialty pediatric health plan. Now, this is developing a managed care plan or a health plan for their specific patient population. And this would be a new line of business for GLAFC in an area that they currently do not have experience in, and it would require them to take on full risk for this patient population. The third option is an accountable care organization, which is a partnership between organizations to improve the access, cost, and quality for a specific patient population. Now, some of the most successful ACOs, such as Nationwide Children's Hospital and Kansas City Children's Hospital, have had years of experience with taking on this risk for their patient population, and they have the infrastructure in place to be successful in this area. And again, GLAFC does not have that infrastructure to really pursue this at this time. And this is why we suggest GLAFC doing a value-based care model by partnering with physician groups, because they can start small, taking the small steps in order to eventually be able to develop an ACO if they choose to. And this also has lower startup costs compared to the ACO model. Now, there are several key stakeholders involved in this in order for this to be successful. First and foremost, the payers, the Medicaid managed care organizations, the Riverside community itself, and the community organizations that are also helping with the access to delivery and delivery of care. The children, the patients that are going to be in this children's hospital, and their decision makers, and those are the families that are also involved. And last but not least, the physicians, who are the key component to this value-based care model. We really want to make sure that we have them on board and aligned with the decisions that this value-based care model will be making.
Now, the Caring for Riverside initiative is a three-pronged approach to addressing the issues currently facing GLAFC. It consists of a cost reduction strategy to reduce the high supply and high salary expenses, a primary care expansion strategy which will build upon partnerships with local physician groups, and a payment model that reimburses the physicians not only for the cost of care, but for the value and the quality of that care as well. Lastly, a care management model that encompasses a family-centered medical home that provides accessible and compassionate care to the children, and a care coordination model that creates a seamless transition between GLAFC and the primary care physician offices. Now, GLAFC is currently facing high salary expenses. They have over 2,000 employees for 176 beds, resulting in a staff-to-patient ratio of 11.6. This is higher than other children's hospitals in the California region that have a staff-to-patient ratio of between 8.2 and 8.8, and it is significantly higher than the national average for all hospitals of 5.6. So how can GLAFC address these high salary expenses while maintaining the morale of their employees? We're suggesting that GLAFC ensure that all of their employees are performing to the height of their license and ensuring that they're performing the duties within their job descriptions. Secondly, staff reduction through attrition. And lastly, out-counseling of underperformers, empowering all employees to meet quality metrics set forth by GLAFC and to meet the standards that GLAFC sets forth to provide quality health care. Through these methods, GLAFC could see a cost savings of 7.5%. Now, to address the high supply expense, children are not just small adults. They are unique beings that need medical supplies tailored to their growing bodies. Therefore, in order to receive discounted prices, we propose that GLAFC partner with a group purchasing organization. They can also implement a just-in-time process improvement, which will help reduce waste in pediatric supplies. Through these two methods, GLAFC could save 13%. Now, we propose that GLAFC partner with Novation, a group purchasing organization that has a great deal of experience in pediatric supplies and cost savings. Through this partnership, they could save 10% on their supplies. Secondly, a just-in-time method. This transitions GLAFC from ordering supplies just in case to ordering the supplies just in time. And one of the methods they can do to ensure this is the Kanban method. This will take pediatric syringes, for example. Instead of ordering syringes in surplus and having those syringes just waiting in the stock room, as syringe bins become empty, a barcode scanner would be used to notify the distributor to replenish GLAFC's supplies. This has been very successful at Seattle's Washington Children's Hospital, and they saved $2.5 million, the equivalent of 3%.
So at the heart of the Caring for Riverside initiative is this value-based care model, and it's comprised of 4 key elements: The first one is the physician partnerships. We recommend that GLAFC identify key physicians within the Riverside community to expand their primary care network and add convenient locations and hours for patients of the Riverside community. Secondly, I'm sure that everyone has heard of the patient-centered medical home. However, in pediatric care, it is important to address the family's role in developing the care plan for the patient. We recommend that GLAFC identify the family's values and work with the family as well as the other physicians to coordinate an overall care plan for the patients. Finally, or additionally, primary care. Now this works in conjunction with the first bullet point, and this focuses more specifically on the aforementioned chronic issues that Isaac talked about earlier, which are ADHD, asthma, and diabetes. Now, these are making sure that these 4 conditions are managed in the primary care setting and increasing medication management with those related conditions. And finally, the payment model. This ties physician payments to quality metrics, which we will discuss momentarily. But first, I would like to talk about the criteria that we recommend GLAFC use for identifying their key physician partners. First is the commitment to the community. Gabrielle mentioned earlier that GLAFC is relentlessly committed to providing quality and compassionate care to the Riverside community, and we recommend that GLAFC partner with physicians who value those same commitments to the community. Secondly, having an enhanced access to care. This is just having convenient locations and as well as walk-in centers and urgent care centers for patients to use within the Riverside community area. And finally, a focus on primary care. Again, this works in conjunction with the other 2 partnerships, and we want to make sure that the partners that GLAFC, the physicians that GLAFC partners with, have a primary care focus, and that's how our value-based care model will succeed. So through these criteria, we've identified the Riverside Physician Network. It has a 25-year history within the community of Riverside, so it's located within the city of Riverside itself. They also have over 60 primary care physicians within their current network and 3 after-hour walk-in clinics. So if we branch out of the city of Riverside and focus specifically on the northwest and southwest regions of the county, we identified pediatric partners. Now, we selected pediatric partners specifically because they have bilingual pediatricians who aim to address the diverse makeup of the Riverside community. And they also have board-certified pediatricians. So this map shows where GLAFC is currently located. The red X's indicate the Riverside Physician Network, and those are located within the city of Riverside. And again, expanding broader is the pediatric partners within the northwest and southwest regions of Riverside County.
Now, in order to incentivize these physicians to improve quality of care and also improve the health outcomes of this patient population, these children of Riverside, we suggest developing a retrospective episodic bundle payment for the 3 chronic conditions: asthma, diabetes, and ADHD. Now, in order for this to happen, GLAFC would have to enter into a contract with the Medicaid managed care organizations of Riverside. And once they do that, they will be able to develop a provider portal in order to identify the principal accountable provider. Now, this episodic bundled payment period is over 1 year. The provider portal will be utilized by the physicians. The physician, when a patient comes to a physician, the physician will enter in all the data, all the claims, and everything that happens within that period. And the provider portal will then identify who the principal accountable provider is. Now, if the average total cost of the principal accountable provider is lower than the average total cost of all physicians within that network, they will be able to share in the savings with GLAFC. Now, this is a snapshot of what the provider portal would look like. Now, on the top left-hand corner, you see the total number of asthma episodes that the physician treated. And this will help identify who the principal accountable providers are. Now, once this principal accountable provider is determined, the average cost of care will also be determined and be compared to other providers within this network. And as I said before, if their average cost of care is lower than the total average cost of care of all providers, they will be able to share in the savings with GLAFC. Now, in order to be eligible for these savings, they must also meet quality metrics. I just want to identify one of these quality metrics. So this is the asthma. For asthma, the percentage of patients on the appropriate medication. Currently, the national average is 68%. But we want to bump that up to 80% to really ensure that the patients and the children of Riverside are getting high quality care from their physicians. And then the physicians are also incentivized by that.
So what processes are involved and how does this look for the patient? So a patient presents to the ED with, say, an asthma attack. Upon discharge, a patient navigator will contact central scheduling, who will schedule the patient an appointment within 12 to 48 hours to see a physician. This physician will be located within the Family Center Medical Home, placed within the ambulatory care center. Once in the Family Center Medical Home, they will be paired with a primary care physician and a care team that will work in conjunction with the family to develop a care plan that the family can follow while at home in between visits with their specialist and their primary care physician. This same care coordination model could be used within the inpatient setting to address those high length of stay and readmission rates. While in an inpatient setting, the care team and the primary care physician will work together to develop a care plan to plan the patient's care from admittance to discharge and beyond to reduce those readmission rates. Now, if you'll take a look at the Riverside implementation timeline, the red represents the cost reduction, the blue, the primary care expansion, and the green, the care management. I want to address your attention to year one. This is where the cost reduction strategies will really be placed and the planning will happen in conjunction with planning the provider portal with the physicians to ensure that it is user-friendly for the providers and their care team. In years 2 and 3, this is where GLAFC will really see their cost savings and where they will see the fruit of their labor.
So you're probably wondering, how can GLAFC finance this Caring for Riverside initiative? The answer is simple. By applying for the Proposition 3 grant, which is a grant that already allocates funds, up to $98 million of funds available for children's hospitals within the California area. Now, these funds are used for renovation and financing children's hospitals and increasing access to care for vulnerable and underserved populations. We have determined an estimated proposal need for the Caring for Riverside initiative, which includes $15 million for the provider portal, which Isaac touched on briefly, and that's making sure that the provider portal is implemented within the various physician groups and practices that we recommend GLAFC partnering with. And with the Kaban method or just-in-time methodology, there's an upfront cost of $200,000 associated with that. Now, GLAFC is currently eligible to receive $98 million. However, we are only requesting $15.2 million to focus on the cost reduction and the implementation of the provider portal. However, those funds the remaining funds will still be available, and should GLAFC decide to pursue an accountable care organization in the future, they can use those funds to help develop their infrastructure with that.
Now, this is the 3-year operating budget. I want to point your attention to the gross profit margin. Well, currently, GLAFC is at a negative 1.8%. With this Caring for Riverside initiative, we believe by fiscal year 2016, they will be able to move to a 1.2% gross profit margin. Now, really, in order to measure the performance of this Caring for Riverside initiative, a balanced scorecard focusing on 3 key result areas, operational performance, quality, and financial performance is necessary. And again, I want to point to your attention to the profit margin. Currently, GLAFC is at negative 1.8%. But with this Caring for Riverside initiative, we strongly believe that GLAFC will be at a 1.2% profit margin and also in the green in the other key result areas. And with this, we want to bring it back to high quality,
Compassionate.
Family-centered.
These are the components of the Caring for Riverside initiative. We talked about a 3-pronged strategy, with the first focusing on cost reduction, Secondly, we recommended the Riverside Provider Network and the Pediatric Partners as a way to develop and expand GLAFC's primary care network. And finally, we talked about a care coordination model that focuses on the family values and increasing access to high quality and coordinated care. This concludes our presentation, and we'll open it. These are our references, and we'll open it at this time for questions.
Great.
So, go ahead.
Okay, great presentation, thank you. In fact, that's an area of interest of mine. So, a couple of questions, and you did address, you went into the thought process behind asthma, diabetes, and, behind asthma, diabetes, and ADHD. And so the perception you're giving me is that you're gonna eventually get these out of the emergency department, particularly asthma was a focus, correct? So how are you gonna connect, and I saw how you have the connection with a physician, how are you gonna backfill when you start, kind of cannibalizing your ED and taking these out? You're gonna further decrease your profit margins from what you're getting from those cases in your ED. So how are you gonna backfill that? That's question one. And question two, to decrease your cost, one of the questions you mentioned, one of the statements you mentioned was a staff reduction only by attrition. So no RIF, you're just gonna decrease the volume and let people naturally retire or leave the organization without a strategy around staff reduction? Those two questions, thank you.
So could you repeat your first question again? How are we going to replenish, backfill?
Right, from the asthma, from the cannibalizing your ED by taking out some of those non-emergency cases from those diseases that you mentioned, and manage the staff reduction other than the strategy around that besides just attrition.
Right.
Okay. Well, in terms of backfilling the ED, we're proposing that we'll see a 2.2% reduction in that. So the total ED volume will not be affected. However, it will reduce those non-emergent conditions so that those people presenting to the ED are people that are going to be admitted to the inpatient units, and where we'll see the revenue generation from those severe conditions. And through backfilling, we project that there will still be patients coming to the ED. There will still be, we may not reach every Medicaid patient with these conditions, so we will still have patients presenting to the ED. And in terms of the staff reduction through attrition, that is our mid-level method to reducing the staff. However, if push came to shove, there would be the out-counseling of the underperformers to reduce staff. However, that is the last resort because we want to make sure we maintain the morale of the GLAFC employees.
And to also focus on reevaluating the job descriptions. So we want to make sure, and if we can go to the slide that talks about how we're going to evaluate the staff, we are going to reevaluate the staff, and as Gabby mentioned, out-counseling and staff reduction through attrition, those are kind of our last resource, and we just want to raise performance standards for GLAFC.
And once you raise those performance standards, either they meet the performance standards or they don't. And some of the employees may decide that they do not want to, move on and meet those performance standards, and they may just, on their own decide to leave, which would help two things. It would help with performance, it would increase the performance, and it would also reduce the number of staff, the high number of staff that we did mention. They have over 2,000 employees for a 176-bed hospital, whereas you have the Children's Hospital of Orange County that has over 250 beds, but less employees. So if you benchmark against the other children's hospitals in California, their staffing numbers are very high.
So you have aggressive and well-intended cost reduction strategies. How did you estimate the savings from the can ban and the savings from the staff reduction? How did you get to those numbers?
Well, for the Kanban method, Gabrielle mentioned that Seattle Washington Children's Hospital previously saw a $2.5 million cost savings with that. We wanted to be more conservative for GLAFC and just use a 3% estimation for that. And if we can go to the financials for the cost reduction savings so we can walk through that with the board, please.
Which one?
You save yourself some time. We got it here.
Right. Okay.
In terms of staff reduction, literature show that you could save between 5 and 10% on your staff by implementing those methods. Therefore, we wanted to give a conservative number to show GLAFC what they could expect to see at the mid-level. So 7.5% to remain conservative, to show if you put in the work, you'll see more than 5%. However, realistic enough that you don't expect, oh, we didn't reach 10%. It's a very attainable percentage in reducing the staff.
So you based your 5 and 10% just on industry?
Yes.
Correct.
Okay, thank you.
So following up on that, is there a central scheduling system in place already?
Yes, that is what we assumed with the, we assumed that they do have Epic. So the system that's there is already in place, and we will just be utilizing it for this care coordination.
And
model.
the physicians that you would be partnering
The
with?
physicians that we will be partnering with will be using the provider portal that will be put in place
Okay.
to help with that.
And the cost for the provider portal, is that
The provider portal.
reflected in here?
Yes. We estimated that will cost $15 million, and we got that again from industry standards and best practices that current children's hospitals have used the $98 million for that.
Electronic medical notes.
Right.
And is that just for the portal? Does that also cover training for the portal?
Right. So with the provider portal, I think that includes all of those costs. So there will be a learning period for implementing, because we can't expect providers to just automatically pick up this new system. So we did incorporate that as well.
Right,
Okay.
and if you look back on our implementation timeline, we give it space so that they do have time to train and learn the system before it's actually fully implemented.
Perfect.
You spent a lot of time talking about the outpatient strategy, and I'm looking at your 3-year operating budget. So I'm curious about what portion of that revenue for the budget is attributed to the inpatient side, and how you're projecting admissions on the inpatient side.
So we focused our strategy on outpatient and ED. The assumptions that we used for the inpatient was based off of the previous year's budget. So we found the average revenue per visit or per patient day, and then projected that out for the 3 years. And then after we did that, we implemented our cost savings and outpatient revenue and ED revenue and inputted that into the 3-year operating budget to get to the numbers that we did.
So you didn't assume with this value-based strategy that there would be any impact on the inpatient volume,
Well-
or?
Yes, we did. We predicted that there would be an increase in inpatient admissions so that GLAFC could focus on those higher acuity revenue generating conditions that will generate more revenue for the organization.
Right, so our strategy is making sure that some of these chronic conditions that are mismanaged do not end up in the inpatient units. So those inpatient beds are focused on the higher acuity services, such as the ones that Gladys mentioned.
But did you take into consideration the change in the payment system, moving from to DRGs? Did you take that into consideration when you were projecting? Because I think you mentioned that you took an average cost per patient day. But as we're moving to DRGs, did you look at what that impact might be in these projections?
We did not. What we did was just use the average cost or average revenue.
Thank you.
And in your pro forma, did you account for any inflation, and at what rate?
Our inflation is not.
It's not, okay.
So thank you for your presentation. What will make Riverside Physician Network and Pediatric Partners select GLAFC over the other hospitals or systems in the area? And then my second question is, can you explain a little bit more, or if the physician payment model is at all tied to the quality measures that you outlined?
Well, currently, we, as far as selecting, why would the Riverside Provider Network select GLAFC? GLAFC is the only pediatric standalone hospital in the Riverside County, so we assume that we could leverage that partnership by that. And we also would recommend that GLAFC identify a physician champion so that we can work with both the pediatric groups to gain just a partnership and buy-in for those for coming to GLAFC.
And this relationship would also help improve the care of their patients that they see. So we want to build a strong care coordination model, as we mentioned, and through their provider portal, they would be able to see the care that their patient received within GLAFC's facilities. So when that patient represented to them, they would know my patient received this care at GLAFC, and this is the new plan that that team implemented for them. We can build off that to ensure that our patient is still receiving the best care.
So did you model the expenses of a care coordinated